This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending neurosurgeon.
And I'm Dr. Alara, a research fellow. Today we're looking at a fascinating new study from the University Hospital Basel, published in the journal Neurocritical Care in 2026.
It's a pleasure to have you, Alara. Today's topic is something every neurosurgeon, resident, and ICU nurse thinks about daily: external ventricular drain-associated infections, or EVDAI. Specifically, the paper is titled Impact of Hemorrhage Extent on External Ventricular Drain-Associated Infections in Aneurysmal Subarachnoid Hemorrhage.
Exactly. We know that in the context of aneurysmal subarachnoid hemorrhage, ASH, the insertion of an EVD is a common neurosurgical emergency procedure. It's primarily used to treat acute hydrocephalus and reduce intracranial pressure. In fact, the paper notes that up to 50% of these patients require an EVD.
But that life-saving drain comes with a cost. Nosocomial meningitis and ventriculitis caused by EVDAI remain the most frequent EVD-related complication. Most literature cites a range of 3 to 9%, but it significantly increases patient morbidity, hospitalization time, and healthcare costs.
Right. And while we've studied risk factors like duration of drainage or frequency of sampling, the authors of this study, Florian Ebel and his colleagues, noticed a gap. They wanted to know if the radiological quantity and anatomical distribution of the blood itself, the subarachnoid and ventricular blood, impacted infection rates.
It's an intuitive question. We often see the patients with the thickest blood having the most complications. Ilara, walk us through how they set this up.
This was a retrospective analysis spanning quite a long period, from 2009 to 2023. They looked at 562 patients who underwent emergency ventriculostomy, but after exclusions like non-ASH cases or patients who died within 48 hours, they ended up with 194 patients and 228 EVDs for analysis.
That's a robust time frame. And they use some specific radiological scales to quantify the blood, right?
Yes, they didn't just look at the Fisher grade. They used the Barrow Neurological Institute, or BNI, grading scale for subarachnoid hemorrhage and the intraventricular hemorrhage, IVH, score. They also looked at the presence of intracerebral hemorrhage, or ICH.
Before we get to the findings, how did they define an infection? That's always the point of contention in EVD studies.
They used modified criteria from the CDC and the Infectious Diseases Society of America. They categorized infections as definite if there was microbiological confirmation, like a positive CSF culture, or suspected based on clinical and biochemical findings. That means a fever of 38 degrees or higher without another source, plus a CSF profile showing declining glucose, increasing protein, or increasing pleocytosis.
And crucial for the residents listening, all cases were independently reviewed and confirmed by an infectious disease specialist and the hospital infection control team to minimize bias. So, what did they find regarding the infection rates?
Their overall EVDAI rate was 14% per patient and 12% per EVD. That's a bit higher than the 3 to 9% often quoted in older literature, which might reflect their rigorous screening or perhaps the severity of the patient population they treated. Out of those 27 infections, 15 were definite and 12 were suspected.
Now, let's get into the meat of the study, the correlation with the blood volume. What did the BNI and IVH scores tell them?
This is the most significant part of the paper. They found that EVDAI was strongly associated with a larger subarachnoid blood clot. Specifically, patients with a BNI grade 4 had an odds ratio of 6.66 for developing an infection. That's a massive jump.
A 6-fold increase. That's clinically very significant. And what about the blood inside the ventricles?
Similar story. Higher IVH scores were associated with EVDAI, with an odds ratio of 1.33. But there was also an interesting finding regarding the location of intracerebral hemorrhage. In the EVDAI group, 20% of the patients had blood in the posterior fossa, compared to 0% in the non-infected group. That yielded a p-value of 0.004.
That's a striking difference. Posterior fossa blood as a potential harbinger for infection. Did they find an independent correlation when they controlled for other factors?
They did. The multivariable analysis confirmed a positive independent correlation between larger blood clots and the risk of infection. But even more interesting for those of us managing these patients in the ICU was the timing of the infection.
Right, the Cox regression analysis. Tell us about the onset.
They found that higher BNI grades and higher IVH scores didn't just make infection more likely, they made it happen sooner. Larger hemorrhage extent was associated with an earlier onset of EVDAI.
That is a vital clinical pearl. If you have a patient with a BNI grade 4 and a high IVH score, you shouldn't just be watching for infection, you should be on high alert much earlier in the clinical course.
Exactly. The authors suggest that the quantity and radiological distribution of subarachnoid and ventricular blood eventually accelerate an earlier infection onset.
Let's pause and think about why that might be, based on the paper's discussion. Why would more blood lead to more infection?
The paper suggests a few possibilities. One is that blood and its breakdown products in the CSF might interfere with the local immune response or provide a more favorable environment for bacterial growth. Also, patients with more extensive hemorrhage often require longer drainage times and more frequent manipulations, though the correlation with the initial blood volume remained independent.
It's also worth noting the total cumulative EVD days. They had 2,258 EVD days in this study. When we look at the logistics, more blood usually means more sludge in the system, more EVD irrigations, and potentially more opportunities for contamination.
And let's talk about the organisms they found in those definite cases. It's the usual suspects for nosocomial meningitis. Staphylococcus epidermidis was the most common, followed by Staphylococcus aureus and Enterococcus faecalis.
Consistent with skin flora being introduced at the time of insertion or through subsequent handling. Now, Ilara, what are the limitations we should be aware of?
Well, it is a retrospective single-center study. While the 14-year span provides a lot of data, clinical practices might have evolved over that time. Also, they included suspected infections, which, while clinically realistic, adds a layer of subjectivity compared to only looking at culture-positive cases.
True, but in the real world, we treat suspected ventriculitis just as aggressively as definitive ventriculitis because the stakes are so high. To me, the most compelling takeaway is the use of the BNI and IVA scores as predictive tools.
I agree. It moves us away from just saying more blood is bad to having specific scales that can help us risk stratify patients from day one. If I see a BNI grade 4 on that initial CT, my threshold for sending a CSF sample or checking for early signs of fever is going to be much lower.
Precisely. It guides future research too. Maybe these high-risk patients are the ones who would benefit most from antibiotic-impregnated EVDs or specific early intervention protocols.
The authors conclude exactly that. They state that these findings should help guide future research on EVD-AI prevention in patients with ASH.
Well, this has been a great deep dive into a very practical paper. For our residents and students, remember that the radiological extent of the hemorrhage, not just the clinical grade, is a major player in the risk of infection.
And watch those posterior fossa clots.
Absolutely. Thank you, Ilara, for breaking down the data.
Thank you, Dr. Aris.
That's all for today's episode of the Neurosurgery Hub podcast. Stay sharp, stay curious, and we'll see you in the next one.